Thank you very much, Paul, for that kind words. It is indeed a privilege to be here on a topic of antibody, in particular in the context of the management of snakebite from the developing country perspectives. As I was telling Paul in an email, I started life initially actually in clinical immunology. But it was on the topic of therapeutic antibodies and realizing that in the country I come from, it's a major problem. That was when I took the detour into infectious and tropical diseases. So basically, my presentation will be detailing challenges, global challenges, and I'll be highlighting medical challenges, production, manufacturing challenges, and also operational and logistical challenges of deployment of antivenom and antibodies. So snakebite is a major problem, as Kofi Annan here mentioned. It is the biggest public health crisis you probably have never heard of. Indeed, as Paul mentioned earlier on, you have a burden of at least 1.8 million annually and at least 80,000 deaths annually. And recall that these are estimates, and we think it could be a lot higher than these figures. You have pockets throughout the world, throughout the tropical world, where it is a major cause of disease and death. In this panel from Central Africa Republic, courtesy of MSF, you could see in Ethiopia, you have about 600 annually. In Central Africa Republic, you have about 750 annually. South Sudan, another 350. And there is some bit of seasonality. As you could see here, May, June, obviously coinciding with rainfall, you have a higher peak. In my own native Nigeria, you have about, in one hospital, we have about 4,000 cases annually. This is one particular hospital where we maintain our clinical research site. But throughout the tropics, it's an issue. You could see here among Burmese rice paddy farmers, it is a common problem. And at some point, snakebite is the 5th commonest cause of death in that country. By way of the clinical manifestations, basically, you could see injuries, and given the variability in the toxins, so in this conference antigen epitopes, you may see cytotoxic tissue damage, you may see bleeding dyscrasias, you may see neurotoxicity because of the toxins may target the neurotoxin pathway. In this panel, you see someone bitten by a neurotoxic cobra, can't hold his head, can't open his eyes, and oftentimes they die if they're not intubated timely. In addition, depending, you may have things like rhabdomyolysis in some snakes that cause muzzle damage, among others. Given you could see the level of variability in the venom toxins, you could see there may be hemotoxins, there may be neurotoxins, there may be muzzle toxins, and also this differ. Some are enzymes, some are proteins, some are small amino acid proteins. And like Paul mentioned, there could be even intra-species variation in addition to variation based on geographic setting. However, for us working in West Africa with a snake that predominantly causes bleeding dyscrasia, we have been lucky to the extent that the antibodies, these polyclonal antibodies, have been found to be very useful in reversing the envenoming process to the tune of about 80% of patients bitten by this small, humble snake, carpet viper. You could see reversal of the bleeding dyscrasia to normality in up to 80% of the cases, i.e. a patient is bitten, is brought to the hospital, you do a simple test, the blood is not clotting, and then you administer antivenom, Within 6 hours when you come back, the blood now is restored to normal clotting, and you would have known that your anti-venom has worked. But with other forms of presentations, notably tissue toxicity and neurotoxicity, especially presynaptic neurotoxicity, the antivenoms have not been as promising in resolving clinical pathologies. We've shown that in our setting with the carpet viper, antivenoms reduce mortality by over 3/4. So a snake that is associated with a mortality of 20%, you have a reduction to less than 2% in most instances, meaning over 80 or so percentage point. But a major biologic or medical challenge is the fact that you do not have the same level of efficacy or effectiveness with neurotoxicity and with tissue damaging venoms. And here you have indirect evidence during a 36-month period when you have antivenoms for 34 of the 36 months. And suddenly during a 2-month period, there was a stock out of antivenom, and somehow the mortality and the risk ratio of dying sort of doubled during the period when you lack antibody. This is another challenge, the fact that you may not be able to do a randomized controlled trial with a placebo to get an absolute efficacy, given the fact that the mortality is high. You cannot give any arm, any group placebo. So in that sense, we have to use this observational data such as this. As was mentioned, the animals, horses, sheep are the traditional ways and methods for developing antivenoms for over 100 years, and they still remain the ways to get commercial polyclonal antibodies or antivenoms in this instance. You know this better than me, the different formats in use. You have the whole immunoglobulin G. Of course, you have the pepsin and papain digested fragments. All of them have been tried. The whole IgG and the pepsin digested fragments are the ones that have some commercial viability given experiences with the papain digested fragments. Here you have a timetable of some of the developments in the antivenom production from the 30s to date, from the development of pepsin digestion through the definition of allergy, through clinical trials of various antivenom formats. Some years ago, we established this particular challenge with small molecular weight papain digested the antivenom, wherein it came out newly and we tried it. You have an initial restoration of clotting, but within 12, 24 hours, given the molecular weight, somehow you have a recurrence of the envenoming or the poisoning. This is a snake that causes bleeding. You are able to neutralize the bleeding within 6 hours. The person stops bleeding, and he has now a clotted blood. But after a day or less than a day, when you go back thinking you've done well, suddenly he starts bleeding all over. And you have to redose him with the same antivenom before he again neutralizes. I guess this may be a challenge with some of the formats that will be considered, especially the small molecular weight format. And I guess in a way, it's the reason why the papain digested antivenoms are generally not in use, given the fact that restoration of clotting is not as durable. Another challenge that we have medically is the issue of early adverse reaction. Here, Jose Gutierrez gave a detailed incidence of early adverse reaction ranging from as low as 3% in some of the ones that are very well produced to as high as 88% in antivenoms, mostly in South Asia, in Asia. But in between, in our own setting, we have about 15, 16, 20% But fortunately, mortality is not a major issue. Maybe less than 1% or about 1% may die from the early adverse reactions per se. Our patients present with typical the reactions, urticaria reactions, pruritic reactions within 30 minutes of administration. You could see hives here. Here again, you could see hives and urticaria on the trunk, and occasionally you could also see periorbital edema and even anaphylaxis in some victims of early adverse reactions following antivenom. Recently, we analyzed data we collected for 2021, January to 2021 to December, and in routine use, outside trial, 2,400, we got about 98, about 4.1%. As I said, in rigorous trials is higher than this, but this is day-to-day without proactive surveillance. And you could see that it's mostly pruritus, urticaria, pyrexia, anaphylaxis, about 2%, and others about rigors, difficulty in breathing, among other things. The pathogenesis of this, there are several factors, multifactorial, times contamination with lipolysaccharide, lack of good GMP, the purity, and the issue of aggregates, among others. Sometimes back in the late 90s, we were trying a new antivenom, and we found very high levels, 57%, much more than what we are used to of early adverse reaction. And later, it was found that there were aggregates and D-dimers, and that was what accounted for that. And when it was purified, it sort of reduced to a much more manageable level of 10 to 20%. So this again raises the issue of good manufacturing practices as a challenge for a disease affecting impoverished populations. Another challenge is that of definition. There are several definitions out there. These early adverse reactions, are they type 1 reactions? Are they anaphylactic reactions, anaphylactoid reactions? Are they type 3 reactions? Are they IgE or IgG mediated reactions? Increasingly, however, there is improvements in the definition, and nowadays is not as much of a challenge as before. As I said earlier, the tissue damaging venom epitopes or toxins are the ones that antivenoms have not been shown to be as useful in somehow reversing the damage. You could see here in tropical Africa, a child placing his hand in a rodent hole and bitten by a carpet viper coming in with this sort of damage. It's so common. Oftentimes, it ends up in amputation. So in those areas, amputation, it's one of the consequences of snake bite, or you could have severe lower limb damage, as in this child. And the amputations may be surgical, may be just spontaneous follow-up, and may just be a non-viable foot that if you don't remove, potentially the victim will go on dying from secondary infections. So as I said, the antivenoms reverse the clotting abnormalities in as high as 75 to 80% in a good randomized controlled trial of 400 patients. But a challenge is how do we introduce new products, given the fact that you may not be able to use placebos, given the risks that I've outlined earlier. So clearly, this is an issue even with next generation products when to be used for snakebite. There has to be a good way of positioning them, given the fact that you may not be able to compare them to placebo, only to existing standards of care. In fact, this lack of placebo studies allowed some others to even question whether antivenoms are ineffective, really. Recently, in a data we are currently analyzing, we in an observational study, we looked at about 1,500 cases in 2021. And we looked at the top panel who were not given antivenom at all because they didn't merit, there were no clinical indications for it, and they all had normal clotting. Normal healthy people have clotting blood. And then we have another group of 1,300 patients who have incoagulable blood, and they were administered antivenom over time at 0 time. I could see they are approaching normality by the time they were 4 days into hospitalization. It's approaching 100%, suggesting that these antivenoms are very useful in restoring clotting abnormalities. However, we cannot do a head-to-head antivenom versus placebo study. Another issue is that of classic phase 2 studies in normal healthy people. Again, given the fact that polyclonal antibodies or antivenom in this case is associated with early adverse reaction, then can you administer it in healthy people? Because the ethics committees may not easily allow for that. These are ways we have to consider ways to try and circumvent that. We did something like this. We borrowed from oncology years ago, the so-called continual reassessment method, the 3+3 dose escalation design with new sets of antivenoms, about 3 of them. However, I guess with newer agents that are considerably safer, perhaps this may not be an issue given the fact that they'll be a lot safer than polyclonal antibodies. And there are newer approaches. I think there is the adaptive method that has been introduced, said to perhaps be another way in addition to the continual reassessment method in evaluating drugs for this. This is Nick Caswell's slide showing the manufacturers globally and the antivenoms globally, about 36. And you could see the paucity of manufacturers in sub-Saharan Africa, which is probably, along with India, among the highest burden countries for snakebite. So the other issue of challenge is that of the security of supply. Just like we have security of supply issues for military, for gas, for power, among other things. When we applied this to antivenoms, there are several issues. Things like diversity of supply is not as robust, expenditure on antivenom, given the lack of affordability, given where snakebite is common. The infrastructure in many of these countries is sort of weak health systems, and also the stability of importing countries. Many of the countries where snakebite is common, as in Africa, are also not the most stable countries. The exporting countries are relatively stable. Affordability, access, and equity, given the remoteness of the parts of the world where snakebite is an issue. So clearly, by way of security of supply, there are challenges. And then ownership of production, safety and reliability of supply, vulnerability to disruption, capacity to adapt to market changes, and intellectual property. I would think that this is going to be an issue with the newer products, with the next generation products, rather than the older products. We've shown that these antibodies are highly cost effective, but still affordability is an issue. If you look at the panel below, a cost of 1 vial could go as high as $84, remembering that these are people who perhaps may not make $50 in a month. And some of the products like the South African could be even higher, about $300 to a rural farmer who may not make $300 in the whole year. That is really prohibitive. So that is a challenge. As we look out for next generation antibodies, antivenoms, we may have to look at also what sort of pricing mechanisms will there be in place to alleviate and mitigate against this. The countries themselves, if you look at, they do not somehow invest as much money funding. Look at in the last line, in Burkina Faso, only 4% of victims are catered for with anti-venom. And the annual budget for that is just over $100 $100,000. Similarly, in Nigeria, the picture is no different. The budget is less than $250. And if you recall that this is a country of over 200 million people, clearly this is grossly inadequate. But globally also, snakebite has not done well. When we look at funding for other neglected tropical diseases, the funding per dali, you could see schistosomiasis getting about $4, lymphatic filariasis $5 per dali, snakebite gets 0, rabies gets 0, but a disease like trachoma, the burden of which is very small, gets about $55. So clearly, there has to be a better funding mechanism. And for most diseases of public health importance, you do have mechanisms internationally or universally. Here you see AIDS, TB, malaria, you have the Global Fund, you have PEPFAR, immunization, you have Gavi coming in, tuberculosis, you have the GDF and the Green Light Committee and other entities, you have drugs for neglected tropical diseases, but snakebite really lacks nothing by way of a platform where funding can be provided universally. Another issue we found is that of delay, which is also from the point of view of operationalizing the antivenom. Delay, there are several causes of delay. We found that 1 hour delay may increase the likelihood of dying by about 1% among victims of snakebite. And when we applied the maternal mortality 3 delays, there could be delay in seeking appropriate medical help because they are poor, they are very inaccessible, they don't even go to the hospital. There is also delay in reaching appropriate facility. You may go to the wrong facility that doesn't stock antivenom. And then finally, you may even reach a hospital where there is antivenom, but the healthcare worker may not be knowledgeable to know what antivenom to use, even though you are within that setting. So that is a challenge. Our colleague in Asia, Sanjeev Sharma, was able to show that if you reduce the transportation time or this delay by providing ambulances, you may have a reduction of case fatality from 10.5% to 0.5%, 95% reduction in mortality. This was in Nepal. So clearly there has to be an avenue to improve administration and deployment of antivenom antibody in this case. There are several approaches. The Caswell Center in Liverpool has been trying, along with us in Nigeria, the use of ambulances to see whether we can alleviate this within the context of an operational research platform. Somehow other avenues are being considered. The former Director General WHO was suggesting the use of drone for these high mortality diseases, such as for maternal mortality in inaccessible areas. How do you transfer blood, maybe by drones? Or how do you get anti-rabies immunoglobulin by drone across a river system or across a mountain? And also for snake bites. This perhaps in the future may have a role in curtailing this delay. The other issue, it's that of training. The healthcare workers are not as trained even though they are working within endemic settings. So here in northern Ghana, the mortality was as high as 11%, 11.1% before training. And following training on the use of antivenom, it reduced to 1.3%. So clearly a massive reduction. So there has to be a way to alleviate, to mitigate against this challenge through training healthcare workers, especially in hotspots, on how best to manage snakebite, even if they have next generation antibodies. So as I conclude, I'll say that the major challenges would be medical, immunobiology, early adverse reactions, relative lack of efficacy and potency, especially against necrosis and neurotoxicity, and also the issue of production, manufacturing, quality standards, benchmarks, quality assurance, product development issues and generation of clinical evidence for efficacy, and the disproportionate global production and utilization pattern. And in addition, you have suboptimal supply security, financing, funding, and affordability, and you have logistical and operational issues relating to delay in distribution, deployment, and utilization. So clearly, there is also the need for training. Lastly, all the speakers have helped the WHO in developing this roadmap in 2020, which is hinged on 4 major principles: empower and engage communities, provide safe, effective antivenoms, strengthen health systems, among other things. And in addition, it has things like education, mapping epidemiology to get better estimates, and partnerships and collaboration. So the aim or the target is to reduce snakebite by 2030 by 50%, snakebite 50%, morbidity by 50%, and death from snakebite by 50%. At the end of the day, from 2025, we intend to provide about 3 million antivenoms. But somehow with the COVID disruption, I don't know whether that is feasible, but clearly the roadmap has allowed for next generation antibodies such as the ones we are discussing today. On that note, I acknowledge my colleagues at Bayero University as part of the Venom Antivenom Research Group, and also members of the African Snakebite Research Group here in the audience, Nick Caswell and David Lalu at Liverpool, and Rob Harrison and others, and also some of our funders, the NIHR and the DFID. Thank you for listening. Thank you. Yeah.
Thank you for an inspiring talk. So let's have some questions. I'll start with...
Yes, thanks very much. So I wonder if it's even part of the landscape to vaccinate, because that's a way to get a polyclonal response. I know in the US anyway, there are some vaccines that are for veterinary use. So what about humans in places where it's needed? Is that a solution that's worth considering?
It's a good question. Somehow many years ago in a high burden country in Myanmar, Burma, they did try some use of toxoid, so to say, more like a vaccination against tetanus. But generally speaking, still, even though we say it's common in certain areas, it's not so common to seriously consider vaccination. And secondly, the antigenic epitopes and the complexity of the venoms means that you may not know what particular toxin epitope to target. There are so many of them, as you will hear in the next talk. So most of our attention has been focusing more on developing purer, better refined the antibodies, including monoclonal antibodies and cocktails of these antibodies. Yes.
Thank you for a wonderful talk. One of the things you mentioned is that it is necessary to inhibit these toxins for a longer period of time, since some of the bleeding complications actually come back unless you have enough of the antibody on board. Why is that? Are these toxins long-lived in the body? Do they persist in the tissues? I mean, they all look pretty small, so you would think that they would be rapidly cleared, but that's apparently not the case. Yeah. And the reason I'm asking is because it would constrain one's thinking about what would be the appropriate therapies, which pretty much limits things to antibodies, which are around for a long time.
Yeah. It's also a good question, but truly when we say they're in circulation for long, it's not like for a week or so. We are looking at 6 days, 5 days, 4 days in most instances. And also there is the differences between the snake species. If you look at the carpet viper that I spoke on, it has a relatively heavy molecular weight toxin cocktail. So there you have a lot of the venom toxin staying within the circulation for a longer period of time. And also, it's a balance or a trade-off between the venom toxin and the antidote size. In the instance I gave the example, it's more the Fab that it's small molecular weight that is easily cleared from the circulation, not so much that the venom remains in the circulation for a long period of time. The perpend-digested fragment is the one that is relatively small. It's easily cleared. It's not allowed to remain in circulation to neutralize the antigen epitope. And so I do not know, but as we consider things like diabodies and others, is there a way that we can add something to the molecular weight so that it remains within the circulation, or that it will have a better affinity so that immediately injected, it sort of binds and somehow it's not excreted out of the circulation. So it's more the Fab fragment that was very small molecular weight and is easily excreted. Yeah. Thank you very much.
So maybe I have one question about
Sure.
the we challenge. So once you've been treated with a horse NCM, can you treat a patient again if you have a second bite, or is that because then you would expect a strong response against the horse antibody?
Yes, good question. Yes, you should or you can be treated with the same product. It is likely, however, although it's not proven, that you may have a higher incidence of early adverse reactions. And from the point of view of this particular session, I don't know whether Nick will be speaking about it, but one of the one of the projects we've been working on is to look at those who've been bitten repeatedly by snakes to see whether they have any higher immune response, and to consider using their PBMCs as sources for monoclonal antibody cocktails. I don't know whether either Andreas or Nick will be speaking on this later in the session.
Okay. Well, thank you very much for.
Thank you very much.
So